Okay, we'll start. Good afternoon, everyone. For today, I will be talking about the role of colistin and Aztreonam in gram-negative infections. Okay? These are my disclosures, and I would like to start with showing this. This is a textbook in the US that I was fortunate enough to write a chapter in. And as you can see here, I talked about, I wrote about mechanisms of actions of antibacterial agents. And of course, we will pick some information from this chapter, especially this, no? So, of course, you all know what this is, right? So on your left, this is how a cell envelope of a gram-positive bacteria looks like. No? By the way, I made these figures myself. No? So I'm a little bit proud of it. On the left side, which will be our focus for the, on your right side, which will be our focus for the day, is how gram-negative cell envelopes look like. No? So at first glance, you can see that the peptidoglycan layer is from this side and the other side are very different. So thicker yung sa gram-positive and thinner yung sa gram-negative. And if you really think about it, if you look at this left side, looks like a cake, diba? May crust, and then you have the cake itself, which is the peptidoglycan layer. And of course, in gram-positives, you have the teichoic acid, the lipoteichoic acid there on the peptidoglycan. And of course, the cytoplasmic membrane is like the crust, right? Now look at the gram-negatives, no? To me, it looks like a hamburger, no? So you have the peptidoglycan layer in the middle, but you also have the cytoplasmic membrane or the inner membrane at the bottom. And on top of it, of course, is the outer membrane. And of course, again, the peptidoglycan layer in gram-negatives will always be thinner. No? And just to show the other features of gram-negative cell envelopes, you have the lipopolysaccharides in gram-negatives, no? And also the others. No? Of course, in any mechanism of action, no? Many times we will encounter cell wall synthesis. Okay, so this one, I hope you will be able to also go through this. Kahit hindi yung this particular figure, but this is actually the whole thing. This is how cell wall synthesis occurs. No? So it starts actually on your right side, the UDP, and then you have the enzymes, no? MUR A, MUR B, MUR C, go and down the line. And you can see here that it starts with the UDP and acetylglucosamine. And with many different enzymes, you add multiple different amino acids. No? First, it turns into an N-acetyluramic acid, and then you add an L-alanine, a D-glutamic acid, lysine, and then two alanines. No? Once you've added the two alanines there, no, you already have how you already have how it almost looks like. No? And a couple more processes, and then you transfer it out of the membrane, and there you have it. No? The way that it looks, no? The cell wall is already synthesized, and you see there that some of the antibiotics there are shown as to where they act. No? But in essence, itong nandito sa left side, that is how the cell wall looks like. And eventually, they will cross-link, and you have the peptidoglycan layer that we saw earlier. Of course, thinner in gram-negs, thicker in gram-positives. Of course, we said we'll be talking about Aztreonam. Aztreonam actually works also in that area of the beta-lactams. No? Okay? In this area, sa final part. No? Tingnan niyo, phosphomycin yung pinakauna. No? And then down the line. And then beta-lactams are here at the far end. No? So, Aztreonam's mechanism of action, as we said, binds to a PDP3. No? And this is also only in gram-negatives, and therefore Aztreonam affects only gram-negative bacteria. Inhibiting cell wall synthesis, which we saw, causing bacterial death, no? Kasi pag nasira na yung peptidoglycan layer, protection is less, easier to kill the bacteria. Okay? And it is bactericidal, meaning Aztreonam kills. It's a killer. It's not static. Again, limited to aerobic gram-negative bacteria because it does not bind to the other PBPs that are present in gram-positives and anaerobic bacteria. Now, one important aspect is this, no? Yung second bullet. It has the intrinsic ability or an intrinsic stability pala to metallo-beta-lactamases. Because this is an important part of it. Because a lot of the discussion later will be focused on metallo-beta-lactamases or MBLs. No? Okay, and it is inactivated by some serine-based beta-lactamases. But the most important is yung second major bullet. It's intrinsic stability to MBLs. Now, a little bit about polymyxins. Polymyxin B is one, and polymyxin E is equivalent to colistin. Okay, so you have to remember that it's called polymyxin E. Colistin is polymyxin E. And the polymyxins in general bind to lipid A, found in the outer membrane of the gram-negative bacteria. If Aztreonam was bactericidal, colistin and polymyxin B are extremely bactericidal. Parang ano yan parang detergent level, no? Yung tatawag namin, no? Because of its high LPS affinity. Ano ba yung mga yan? Ano yung makikita natin? But one advantage of colistin over polymyxin B is its anti-endotoxin activity due to its ability to neutralize bacterial LPS. Ano ba yung LPS? Lipopolysaccharide. With also an added ability to inhibit cell division. Okay? So this is another one that I made. No? I hope you can see it. No? Here on your left is the normal, no, appearance, no, of a gram-negative. No? And you see there polymyxin on top. No? I made it into a diamond. No? And it attaches to lipid A. No? Lipid A is there with the lipopolysaccharide, no, on top of it. No? What happens when polymyxin attaches to lipid A? And that's what happens, no, on your right. Polymyxin attaches, causes lipid A aggregation, so dumidikit siya. But once dumikit siya doon, the membrane gets disrupted and it permeabilizes, no? It should be nagbubutas-butas. No? Eh, syempre, pag nagbutas na yun, in addition to pagbutas-butas na siya, the OH, no, the hydroxyl radicals come in and attacks the gram-negative bacteria. Mas lalong masisira, and you see there's leakage of ions, amino acids, cell lysis, and of course bacterial death. No? Okay? So, those are just the basics, no? But in essence for today, we will go for the uses of these two antibiotics. So the latest one, kasi maraming older versions, 2019, but the latest one that we follow is of course the IDSA 2023 guidance on the treatment of antimicrobial resistant gram-negative infections. And this is in general the big picture. So, in-next ko na yung mga hindi siya kasama, yung colistin and Aztreonam. So, for uncomplicated cystitis by ESBLs, pyelonephritis, complicated UTIs, ESBLs, infections outside the urinary tract by ESBLs. No? So, in general, for ESBLs, hindi siya yung ating dapat ginagamit. No? How about yung mga AMP-C producers? No? Enterobacterialis with AMP-C production because of an inducible AMP-C event. No? Therefore, we will focus on the greens. No? CREs, or carbapenem-resistant Enterobacterialis, MDR, and difficult to treat Pseudomonas aeruginosa, and CRABs, carbapenem-resistant Acinetobacter baumannii. So mukhang dun yung role ng both Aztreonam and Colistin. Okay. So tingnan natin, we'll go through this. No? So, again, CRE. No? In the guideline, for CREs, while the testing results are not yet in, no? They mention Cephas avi, Meropenem vaporbactam, Cilastatin relebactam. No? However, in our setting, wala tayo ng latter two, as you know. So, Cephas avi has come to the forefront because of the absence of the others. And we have to, in our history taking, we have to make sure that we ask if these patients have come from countries and received medical care from countries who have high CRE prevalence. Okay? Especially the MBLs. Kaya nga natin minention din yung MBLs. Or, for patients who have previously had clinical or surveillance culture where an MBL isolate was identified. Again, history taking. And sometimes looking at the computer itself for the EMR. And yun na nga, the other possibility, kasi yun, they mentioned Cephas avi, but they also include Cephas avi plus Aztreonam while awaiting the results. It's also a preferred option. Okay? So that's one of the roles of Aztreonam as a second agent. Mamaya makikita natin bakit ba natin dinadagdag yung Aztreonam. But before anything else, let's look at epidemiology. So this first slide on epidemiology is US. Okay, in the US, ano bang marami sa kanila? ABCs. Okay, 86%. And then in the second bullet, ABCs naman 92%. And this is the reason why. Cephas avi has activity versus KPCs and OXA48 CREs. Okay, mamaya we will examine the Ambler classification. But Cephas avi has activity versus KPC and OXA48. Yung Meropenem vaporbactam and Imipenem Cilastatin relebactam, wala silang OXA48. So it's also good that what we have in our country is Cephas avi because it has APC and OXA48 activity. Okay. Now, if you look at that last bullet, neither Cephas avi or the others have activity against MBLs. Okay, so may butas pala si ceftazidime avibactam. Okay. So dyan pumapasok yung ating lecture for today. But before that, US yun, this is Philippines. So syempre we have less data, but of course we do have data. From 2013 to 2018, if you look, ito based on CARBA NP test, NBMs. NBM is one type of MBL, diba? So, marami din pala tayo MBLs. And that, that's something to think about when we start, our thinking on what to use for CREs. Okay? So basically yun. And then let's look at the second. This is a newer one, 2023. And ito yung nasabi ko, let's examine the Ambler classification because this is very important. So class A are serine penicillinases and ESBLs. Okay? Sabi natin ESBL, di masyado. Okay? But sa class A, doon kasama yung mga APCs. Diba? But MBLs naman is in class B. Okay? Class C sa AMCs. Sabi natin, yung Aztreonam and Colistins, di masyado sa AMC. Oxacillinases class D. Again, hindi rin tayo. Now, ito yung, it's just mentioned again, it's another way of saying that avibactam inhibits A, C, some D, but does not significantly inhibit MBLs or the class Bs. Here, I just wanted to show what the different class B MBLs are. Kasi baka malito. So what are they? So kasama dun sa MBLs are the imipenemase, metallo-beta-lactamase or IMP, kasama sa B yun. Okay? Verona integron encoded MBLs, VIM, kasama yun. Okay, sa B. And the NBMs na sinabi natin ngayon, the New Delhi Metallo-beta-lactamase. Again, vaporbactam inhibits A and C, but not those 2B and B. Okay, so may mga butas pa rin yung mga bago nating antibiotics. Okay. So this is the 2023 data. What did they have? No? Mostly CTXM, no? So ESBLs, CTXM, which is class A, no? And then, but they also had some MBLs, no? Okay. Alright. And of course, Avamani and Pseudomonas also had IMPs, and of course, Oxa also. So that's what we have, no? A little bit on colistin, no? So colistin previously, colistin was in 2019. Colistin and polymyxins were actually, they were at the forefront. No? Okay. So previously, it was standard practice to give extended infusion meropenem plus the second agent, no? And frequently colistin, polymyxin B, or aminoglycosides for CRE, with meropenem MICs even as high as 8 to 16 micrograms per ml. However, because of increased mortality in data and excess nephrotoxicity with polymyxin or aminoglycoside regimens, and we know, diba, that they do have higher nephrotoxicity compared to beta-lactams. And maybe that's the reason why from the forefront they went a little bit downward. And we shall see where their place has become now. No? And therefore, in the IDSA, which is the 2023 one, the panel now advises against extended infusion carbapenem with the second agent, no? whether polymyxin, colistin, or aminoglycosides. So it went down. No? So let's go through the guideline bit by bit, no? So that we will, we won't miss anything. No? We'll start with the infections. I won't go through the ones that are X already. No? We'll go through the green light. No? Infections outside of the urinary tract caused by CRE, if NDM production is present, no? The suggested is Cephas avi plus Aztreonam for NDM and other metallo-beta-lactamases. No? Kasi nga yung Aztreonam, siya yung fill in dun sa butas ng Cephas avi. So sa Aztreonam for NDMs and the other MBLs. So that's the underlying reason kung bakit lumabas ito. No? So ngayon may role na si Aztreonam. Cephalosporins, wala sa atin, so let's not talk about that first. No? So again, NDMs, hydrolyzed penicillin, cephalosporins, carbapenems, but not Aztreonam, and therefore that's why we give Aztreonam in combi with Cephas avi. Although Aztreonam is active against NDMs, it is hydrolyzed by ESBLs, AMPC, beta-lactamases, KPC, OXA. Kaya nga wala siya dun sa other Ambler classification, A, C, and D. And avibactam will take care of those. So kumbaga, it's a pair. Diba? Tulong sila. Now, outside the urinary tract caused by CRE, if NDM production is present, no? This is one of the bases, an observational study of 102 adults with bloodstream infections caused by MBLs, no? MBL enterobacterialis. And the only thing that is important there is Cephas avi plus Aztreonam versus combination with polymyxin or tigecycline-based therapy. And look at the mortality of Cephas avi plus Aztreonam. It's 19%, so mababa compared to 44%. So that's the basis for it now becoming the recommendation. Of course, very important yung last bullet. Whenever we use Cephas avi and Aztreonam, we have to monitor our LFTs closely, at least once a week. No? Once you start, usually we check in 2 to 3 days time, and then afterwards, in a week or weekly kung matagal yung treatment. No? Now, outside the urinary tract caused by CRE, if OXA48 type production is present, Cephas avi. Okay? Kasi OXA, di ba? So, nakuha niyo yung principles, no? If it's OXA, then Cephas avi would be enough. Sinama ko na rin yung tetracycline derivatives such as tigecycline, which we have. Eravacycline we don't have, no? Although beta-lactam agents are still preferred, no? Tigecycline is an alternative. But definitely, pag tigecycline, dito tayo pumapasok, no? Kanina, mga cidal agents yung pinag-usapan natin. But tigecycline is a static agent and therefore, it's not for bloodstream infections. We prefer bactericidal fast killers when we have a bloodstream infection. And tigecycline not good in the urinary tract, hindi siya maabot masyado. And that therefore not for CRE, urinary tract infections. Yun. So what is the role of polymyxins based on the 2023 IDSA guidance? No? Polymyxin, colistin are not suggested for the treatment of infections caused by CRE. Kumbaga, di ba, 2019, nandun sila sa taas. Was always there, naibaba na ngayon. But colistin can still be considered as alternative for uncomplicated CRE cystitis. So, yeah, that's still reasonable. Okay. Okay, why? Because of observational and clinical data that showed increased mortality and nephrotoxicity with polymyxin-based regimens, no, relative to the other relatively safer antibiotics. No? Of course, diba? First, do no harm. No? And then concerns about clinical effectiveness of the polymyxins and accuracy of polymyxin susceptibility testing. Okay? This has led the CNSI to eliminate a susceptible category for colistin and polymyxin. Have you noticed that? Hindi, no? So, sa PGH, pag meron kaming CRE, okay, you will never find colistin susceptible, laging intermediate. Okay, and this is precisely the reason. Okay, yung CLSI kasi, sinabi nila, na because of some potential inaccuracies in susceptibility testing, hindi na sila nalalagay susceptible. At the very least, intermediate lang. So, sa atin hindi, ano? Parang naglalagay pa rin ng susceptible, di ba? So, we have to talk to the lab about that. Just to see what their view is in that particular topic. Now, the panel suggests that these be avoided for CRE infections, again, with the exception of colistin as alternative for CRE cystitis, because yung nga colistin better sa urinary tract. And then yung kanyang counterpart na polymyxin B, again, colistin is polymyxin E, no? But polymyxin B should not be used for CRE cystitis due to its predominantly non-renal clearance. Okay. Now dati, 2019, when the polymyxin guidance came out, no? Puro combination therapy, okay? But based on the 2023 guidance, no, the role of combination therapy for infections caused by CRE is no longer suggested. Okay. And the reason for which is because the data do not indicate that continued combination therapy offers any additional benefit, especially pag yung beta-lactam agent already shows that it's susceptible to that agent. Okay. Nonetheless, it's the point really is once may susceptibility yung beta-lactam, doon na tayo sa beta-lactam. And beta-lactam is inhibitory. So continued use of a second agent increases kasi the likelihood of antibiotic adverse events. So that, again, do less harm, do no harm. So the panel does not suggest combination for CRE when there is susceptibility to a preferred beta-lactam agent. Again, that's the difference from 2019 to 2023 guidelines. Okay, so we're done with CRE. We go to Pseudomonas. No? The preferred antibiotic for treatment of infections caused by MDR, Pseudomonas. The suggested approach is that when Pseudomonas aeruginosa isolates test susceptible to a traditional non-carbapenem beta-lactam agent. So, example, ceftaz, cefepime, Infectious, and Aztreonam. Okay? And then carbapenems also. The former are preferred over carbapenems. Of course, we know that. Okay? So, antimicrobial stewardship. Kaya nga ako, kung ako yung nandun sa guideline makers, no, hindi 50 so yung lalagay ko sa simula. Lalagay ko ceftazidime, lalagay ko cerebim, lalagay ko 50 so, lalagay ko yung sequence na, you know, from lowest to highest. No? Because, yan, pag nilagay nila 50 so, it sounds like 50 so again, is the first line. No? When in fact, for Pseudomonas, all of those are effective, no? Including Aztreonam. So, if it's not susceptible to any carbapenem, okay, and that happens, no? But susceptible to traditional beta-lactams, give the traditional agent as high-dose extended infusion. So tayo naman, we give the high dose usually for Pseudomonas, right? For ceftazidime, we give the 2 grams. Cetipine, we give the 2 grams. Hindi walang fluoroquinolones dyan, but fluoroquinolones, we give the high dose, di ba? So, but yun nga, pag beta-lactams, the extended infusion makes use of the PK/PD characteristics, or, you know, it optimizes the pharmacokinetic and dynamic properties of the drug. And of course, repeat the antimicrobial susceptibility testing. Ngayon, for critically ill patients, again, with poor source control, resistant to carbapenems, but susceptible to traditional beta-lactams, it's safer to use ceftolozane tazobactam or ceftazidime. So yun yung sa antimicrobial stewardship natin, no? We have to get a role for all the antibiotics. No? Kasi sayang mga antibiotics if we just focus on this antibiotic all the time. No? So, for Pseudomonas, dapat ang ating lalagyan natin yung ceftolozane tazobactam as our first line. Kasi or else mawawalan siya ng role, and we will have more resistance to ceftazidime avibactam. So kung Pseudomonas, kung papansin nyo, ako I would Pseudomonas, ceftolozane. And because I am in keeping with the guidance, but at the same time, thinking of usage. No? Maraming antibiotics, kaya lang yung usage, dapat we also, look at the usage so that we don't overuse one over others. So again, Pseudomonas, inuuna natin ceftolozane tazobactam over ceftazidime kasi ang dami ng ibang other indications for ceftazidime. Ceftolozane, wala masyado. But at the same time, kung hindi masyado nagagamit yung ceftolozane tazobactam, nababawasan din yung chances ng resistance. Diba? So again, it's reasonable really to, pag Pseudomonas, to use ceftolozane tazobactam. Now for uncomplicated cystitis caused by difficult to treat Pseudomonas, ayun, again, kita nyo, ceftolozane tazobactam na naman yung nauna. Kasi yun yung role niya. And ceftazidime, kung example, walang ceftolozane. But all of them are options. Now for uncomplicated cystitis, okay, single-dose Cobra or single-dose amikacin is an alternative when it's caused by difficult to treat Pseudomonas aeruginosa. No? I think this guidance kinda is not in sync with our local guidelines. Iba sa local guidelines natin, pag difficult to treat organism, nagiging complicated na siya. Sa kanila hindi. Okay. So yun, medyo may konting difference sa guidelines, local guidelines, and the IDSAs. Okay? Colistin is the alternate, no? For, again, urinary tract, uncomplicated cystitis, uncomplicated. Okay, as it converts to its active form in the urinary tract, again, watch out for nephrotoxicity. Okay, preferred for infections caused by Pseudomonas, difficult to treat outside the urinary tract. Kita niyo, ceftolozane tazobactam again. Ceftazidime, preferred. Let's not talk about cefiderocol kasi wala pa naman siya dito. Okay, so for infections outside the urinary tract, bakit yun yung naging recommendation? Because a study of 200 patients, no, of MDR Pseudomonas aeruginosa compare the outcomes of ceftolozane tazobactam versus polymyxin or amiglycoside-based therapy. So favorable clinical outcomes for 81% sa ceftolozane tazobactam versus 61%. So may 20%, almost 20% advantage. And that was taken into consideration. And a smaller trial of 24 patients with imipenem non-susceptible Pseudomonas. Favorable clinical response, 81% dun sa imipenem cilastatin-relebactam compared to 63% only. So, mga around 20% yan, less than 20% when imipenem cilastatin with Colistin. So, we see na the newer beta-lactams have an advantage. How about for the difficult to treat Pseudomonas that produce MBLs? Okay. Preferred treatment is cefiderocol. Okay. Wala tayo so far. Okay. But, yun na nga, there is some extrapolated evidence that ceftazane tazobactam plus aztreonam, so wala tayong cefiderocol. So ito yung magiging option because of the absence of cefiderocol. Ceftazane plus aztreonam because it appears less likely to provide incremental benefit over aztreonam alone. No? So mukhang kailangan pa rin ng combination therapy. Okay? There are isolated case reports in literature that suggest potential, again, big evidence, potential clinical success with a combination. Theory is that it may simultaneously, because of the simultaneous inhibition of the PBPs, PBP1A, 1B, and 3, they may add some benefit over aztreonam alone. Okay? So MBLs, again, we're looking for roles. Aztreonam has a role for MBLs because of its activity there. Okay, so combination therapy for difficult to treat Pseudomonas. Is there a role? No. It's not suggested by the panel. Okay, especially if susceptibility to ceftolozane, tazobactam, ceftazane have been confirmed. So again, so I guess there is a role for empiricism. Ito kasi ang problem sa atin, we are unable to determine which is which. Diba? Di man lumalabas eh. Di natin alam kung NDM. So, in the future, dapat nakatingin tayo sa mga studies made in our country. Kasi pinakita ko yung mga 2013, 2016, and the later one, with regards to the epidemiology of MBLs or CREs, dapat medyo nakakabang tayo sa news. And new studies, para nakikita natin kung sino tumataas. Kung MBLs nagiging majority na, baka, kasi ngayon, our practice is still ceftazane, di ba? After meropenem. But in the future, kung tumataas talaga yung MBLs sa Pilipinas, in Makati, Metro Manila, then we might need to start thinking of ceftazane plus aztreonam as empiric. Probably not yet at the moment. So baka one of the fellows can also, look at the outcomes. Kasi meron naman tayong binibigyan ng ceftazane plus aztreonam. Meron naman tayong binibigyan na ceftazane lang, di ba? So we'll see. Baka merong advantage yun. Kung makita natin, that might change practice. So baka sa first years. Again, toxicities associated with aminoglycosides and polymyxins, which is why combination therapy, again, is not suggested. Plus, clinical outcomes do not demonstrate a benefit sa combination therapy. Sa latest evidence, iba nung 2019, more data, 2023, clinical outcomes based on the IDSA did not demonstrate benefit. Okay, so the role of combination na naman, if there is no preferred agent demonstrating activity against difficult to treat Pseudomonas, tobramycin, if susceptibility is demonstrated, or amikacin, no? Basta an aminoglycoside can be considered in combination with Colistin and Aztreonam, Ceftaz, okay? Kasi wala na nga eh. Okay. So dyan pumapasok yung, yung combination therapy. If there's no other option, then walang susceptible, then you combine. Okay? If tobramycin does not test susceptible, polymyxin B can be considered, and polymyxin B is preferred over colistin if not UTI. Pero if UTI, again, the principle is, if it's urinary tract, then colistin is preferred. Okay? But in essence, combination therapy these days, previously empiric, sila talagang combination talagang first line. 2019, 2023, hindi na masyado. Parang sila na yung combination therapy becomes the last line. So nebulized antibiotics for difficult to treat pseudomonas again does not suggest, the panel did not suggest use of nebulized antibiotics. But I have used nebulized antibiotics. I have a paper on it. You can go and Google it. I have a paper on nebulized antibiotics. And we have used it here. Colistin, we have used nebulized colistin here. But in the past, I did not encounter any bronchospasm. But unfortunately here, nagkaroon ng isa na nag-bronchospasm. So we weren't able to continue it, but we did start it because wala nang susceptibility. So we decided to use the nebulized or inhaled colistin in this. But I've used many. Inhaled meropenem, inhaled colistin, inhaled polymyxin. Nagkaroon na rin ako before. So again, it can still be used if wala tayong options. Okay. Now we move on to crab. What's crab? Carbapenem-resistant Acinetobacter baumannii. So when we have crab, the suggested approach is combination therapy with at least 2 active agents whenever possible. At least until the clinical improvement is observed because of limited clinical data supporting a single antibiotic agent. So dito pumapasok pag crab combination. Okay? And there are 8 trials, and we'll go through the 8 trials. Only one of the 8 trials indicated a potential benefit. There was an anterior colistin dosing in the studies. But here are the studies. We'll just go through them just so we know why we're doing it. So the first study, 210 ICU patients with invasive crab, compared the outcomes of patients receiving colistin alone versus colistin plus rifampicin. No difference. So in that case, colistin is better. I mean, it's colistin because having two antibiotics increases adverse effects. Pero cancer mortality, 43%. Now the second one, 43 patients with crab pneumonia. Colistin monotherapy versus colistin plus rifampicin na naman. Taas, hospital mortality, 73%. In the colistin group, 62% in the colistin rifampicin. So that's not significant. So essentially the same. Number 3, randomized patients, 9 with colistin-resistant A. baumannii. Okay, no difference in clinical response between colistin versus colistin rifampicin. Okay, 80% versus 67%. So that's statistically significant. Yeah. Number 4, patients with variety of crab infections randomized. There were 94 patients who received colistin alone or colistin with IV fosfomycin. Kaya wala tayong IV fosfomycin. So if someone can bring IV fosfomycin, it would be great, Okay. Mortality, 57 versus 47%. So again, not really that different, not statistically significant. Number 5, fifth study, 312 patients with crab bacterial pneumonia, UTI, randomized to colistin versus colistin plus meropenem. Again, no difference. Okay. 6th study, 329 patients with drug-resistant A. baumannii bloodstream infections or pneumonia, colistin versus colistin meropenem. Okay, 46 and 42% clinical failure. Not statistically significant. So for both trials, addition of meropenem to colistin did not improve clinical outcomes. Okay. Number 7, the open label trial compared the outcomes of 47 patients with Crab pneumonia, colistin meropenem versus meropenem ampisulbactam with a total daily dose of 6 grams for a 14-day course. No? Similar na naman. Number 8, Crab pneumonia patients, 39 of them, with clinical isolate susceptible to colistin and sulbactam. So, colistin monotherapy versus colistin and high-dose sulbactam. 8 grams. Clinical improvement by day 5 was observed in 16% and 70% in the colistin versus sulbactam colistin arms. No? So, dito may nakita. Malaki ang layo, 70% clinical improvement dun sa combination. And that achieves statistical significance. Okay? Which is why, no, because of that summary, no, we will see later on what the recommendation is. No? They favor combination of CRAB, combination therapy, because there is a lack of robust clinical data supporting treatment of CRAB with just one agent. Okay? Alright? And number 2, high bacterial burdens are expected in crab due to almost universal delays in initiating effective therapy, and that increases the chances of, number 3, resistance. So those are their reasons why, in this case, they recommended combination therapy. So what are the potential options? Tetracycline derivatives, so tigecycline. Okay. Although most experience now was from minocycline because it's older. No? Okay, but then we don't have minocycline available. No? More of tigecycline. Then polymyxin B, colistins for UTI. We don't have cefiderocol. And because of that study, no, wherein there was a big percentage of clinical improvement compared to the monotherapy with sulbactam and colistin, the panel suggests that the sulbactam or ampisulbactam, which is what we have, should be the component also of the combination therapy, even when there is resistance to sulbactam. So parang siya na yung naging backbone ng combination therapy for CRAB. Okay. So again, sample sizes were small. Combination of meropenem, colistin, or polymyxin B without the addition. So yung combination na dating ginagamit natin, colistin, meropenem, is not suggested for CRAB based on 2 clinical trials. And the panel does not consider available evidence sufficient to suggest fosfomycin. But in our setting, we can't use fosfomycin because what we have is the oral version. Like, so there are other countries like in Cuba, meron silang IV. So, marami silang experience. Tayo wala tayong experience sa IV fosfomycin so far. So, yun. So, now, ampisulbactam, specifically sulbactam, is suggested as the backbone of CRAB combination therapy, regardless of susceptibility. And there was this trial, 39 CRAB pneumonia patients, no? Susceptible to colistin, susceptible to sulbactam. So clinical improvement by day 5 is 16% and 70% of patients. So 70%, yun ang nga sinabi natin, responded, clinically improved when colistin plus sulbactam were given. Ito at least 8 grams. Polymyxin B can be considered in combination with at least one other agent for the treatment of CRAB infections. Again, taking into account that if it's urinary tract, then it's you use colistin. Okay, monotherapy for polymyxin. And when we say polymyxin, that's B or colistin E. Diba? Polymyxin E or colistin. Concentrations of polymyxins in serum achieved in conventional dosing are highly variable. So that's one problem. The dosages required to treat systemic infections approach threshold for nephrosis. So again, do no harm. So narrow yung therapeutic window. Activity of IV polymyxins in pulmonary epithelial lining fluid is suboptimal and generally does not result in adequate bacterial killing in the lung. So similar to aminoglycosides, di ba? That's one of the, kumbaga, parang yung mga butas ng aminoglycoside, poor lung penetration. Diba? Although, pag susceptible kasi, di ba, what can you do? Doon siya susceptible, then we maximize. And then, several reports of clinical failure and resistance during monotherapy. Alright, so we're done with crab. Last na to. Last na yung organism na Stenotrophomonas maltophilia. So the panel suggested two approaches. First line would be co-tri, Mino or Taige, Capiderapol or levofloxacin. However, it's also possible to use as number 2, combination of Ceftazidime and Aztreonam, especially kung unstable yung pasyente. Clinically significant clinical instability or intolerance to the first line. So again, Ceftazidime plus Aztreonam also has a role in Stenotrophomonas maltophilia infections. Okay, and these are the reasons, no? Basically the same as the principle from the others. No? It can be used to overcome the activity of both L1, L2 beta lactamases intrinsic to Stenotrophomonas maltophilia. The L1 MBL hydrolyzes ceftazidime, but not Aztreonam. So again, may nakuha na namang role si Aztreonam. No? While the L2 serine beta lactamase hydrolyzes ceftazidime and Aztreonam, but is inactivated by avibactam. So the avibactam naman yung may role sa L2. No? Kaya savior siya ng dalawa. And therefore, the combination of Ceftaz-Avi plus Aztreonam enables Aztreonam to bypass the inactivation and successfully reach its target EVPs of steno maltophilia. Again, monitor liver enzymes when you're using Ceftaz-Avi plus Aztreonam. Okay. So we're done with the resistant gram-negatives. No? Maliit, no? But Aztreonam is always an option for penicillin or, beta-lactam allergies, yung true allergies. So this is just an example of an allergy pathway in Journal of Allergy. Ang importante dyan, yung first, this one and this one. Okay? Because these are the ones, for example, if a patient has lesions or ulcers involving mucosal membrane from penicillin, used in the past, or nagkaroon ng rash, fever, lymph node, liver, and kidney involvement. So that suggests stress. Yung first one, SJ or PEN. Or fever, urticaria rash, and arthritis, which suggests serum sickness. Avoid using penicillin and cephalosporins or carbapenem. Bakit? Kasi yung carbapenem meron 13 to 40% cross-reactivity sa penicillin. Okay, but ito, so yung sa gitna, how about if hives, angioedema, swelling, laryngeal edema, wheezing, dyspnea, hypotension, needed epinephrine, na-intubate, okay, so that's clinically significant, So it's okay to, dun yung role ng Aztreonam, okay? Okay, you can give Aztreonam right away as your alternative. Although there are other possibilities, you can do test dose for cefazolin, third or fourth gen cephalosporin, carbapenem. Okay, so those are possibilities. Ngayon, pag lower risk naman of allergic reaction, itching only, mild lang, delayed rash, okay, nilist yung allergy, but the caregiver does not even recall any details on that. No? Then, you label it as a mild. Hindi siya talaga true allergy. And you can give the beta-lactam, including Aztreonam. Okay. But you can also do test dose procedure. So ito lang yun, it's the same thing. Ito naman, same with cephalosporin allergies. First, this one, you need to make sure wala siyang history of SJS, DEN, serum sickness, DRESS, diba? Because those are very clinically important diagnoses that you should take into account. Now, again, same. High risk for allergic reaction. Aztreonam is your you can give that already right away, full dose, and then or test dose to others. Okay. And then pag lower risk, Aztreonam is still there, but we can give to others as well. So it's just the same. Pinalaki ko lang. Okay, so that's it. Let me end by summarizing it with this poem that I made especially for you guys. No? Para lang matandaan nyo. Okay? So, I entitled it, Colistin and Aztreonam, Paano Gamitin. So, summary ito eh. So, ito yung pinag-usapan natin. So, I'll start. No? May sinulat ako sa isang libro, sana na may natutunan ninyo. Mga nakabalot sa mikrobyo, manipis sa negatibo. Aztreonam ay para sa ganun. Naninira ng mga bakuran. Nawawala tuloy ang proteksyon. Ang bakterya, buhay, nawawalan. Colistin, nadikit sa lipid A. Ang bakod ay nagkandabutas na. Ang bilis-bilis pumatay. Yay! Saan nga ba ginagamit sila? Una, sa mga di tinatablan ng mga gamot na carbapenem. Isabay dapat ang Aztreonam doon sa ceftazidime avibactam. Para may panlaban sa KTC, Oxa-48 at si Astreo ang bahala sa MBL-PC. New Delhi MBL sama dito. Ang colistin ay hindi daw muna, pero okay kapag nasa ihip. Kung Pseudomonas ang bakterya, Aztreonam at colistin pwede. Sa crab naman, na di alimango, Acinetobacter baumannii, ampicillin sulbactam na combo, at colistin, option sa UTI. Doon sa Stenotrophomonas din, pag di pwede ang levofloxacin, cotrimoxazole at tigecycline, Zabicept at Astreoi, sabay din. At sa panghuli na lamang ito, ang Aztreonam alternatibo. Sa allergic, sa mga katribo ng penicillin, pwede ito. Ayan, natutunan na natin ang mga gamit ng Aztreonam. Pati na din ang OG colistin. Ituloy na natin ang laban. Okay, thank you so much.